IVF or test tube baby is a very common thing nowadays. Many people undergo IVF, sometimes for the want of time, sometimes for late marriage, sometimes there is a real indication of IVF. But nowadays, in last many years, 5 to 7 years, the IVF has undergone a slight change. What we used to do IVF or a test tube baby before was that there used to be a stimulation from day 2 to day 9, day 10. Then there used to be a trigger for ovulation. After 36, 34 hours of the trigger, there used to be a ovum pickup. The minor 5-minute surgery was done. And 3 days or 5 days after the ovum pickup, the embryo transfer was done in the same cycle. So a cycle of an IVF earlier used to be about 26 to 27 days. After 14 days after embryo transfer, used to do beta HCG to know whether the procedure has succeeded or not. The results in the same cycle IVF were about 30 to 35% per cycle. What people found sometimes later, earlier it was by accident, then nowadays it is by design, that if we freeze the embryos and transfer in the next cycle, then the success of the IVF increases to about 50 to 60% per cycle. And this, my dear friends, is called as a frozen embryo transfer. Today, we would be discussing what is frozen embryo transfer, why frozen embryo transfer is done, what are the results and success of frozen embryo transfer, and how a frozen embryo transfer is done. So like I said, why frozen embryo transfer is done? In an IVF, for an ovulation stimulation for female, when we start the injections, we start with normally 225 or 150 or 300 recombinant FSH plus minus HMG in either 75, 150 or 225 dose, depending upon the age, depending upon the body mass index, depending upon the antral follicle count, and depending upon the AMH of female. We decide how much dose is to be given, and then we start on day 2 that much amount of gonadotrophins. We give on day 2, day 3, day 4, day 5, and then we again reevaluate on day 6 with an estradiol level and with the follicles, whether the follicles are growing or not. If the follicles are growing and then they have reached a size of 12, 13, 14 millimeter, then we continue with those same doses of gonadotrophins, whatever we have decided, either plain recombinant FSH of whatever dose, with or without HNG, whatever we had decided before, or if the dose needs to be increased if there is no response. If there is a good response and we have got 12, 13, 14 millimeter follicles, then we add an antagonist dose, cetrorelix 0.25 milligram, and we continue it for 3 to 4 days. Again, we evaluate on 9th day, and if the follicles, the leading follicles have reached about 17, 18 millimeter, then we decide for the trigger that day. Trigger can be anywhere at about say 10 p.m., 11 p.m. because we need to plan for the ovum pickup about 34 to 35 hours after the trigger. So we give a trigger and then we take up for ovum pickup. Ovum pickup is a small surgery, 5 to 7 minute surgery. The patient has to be anesthetized. We take a vaginal needle, ovum pickup needle, do a transvaginal sonography, and then suction, aspirate the ovum out. And depending upon the number of ovum we have collected, we inseminate the ovum with the sperms, do a ICSI, and start forming the embryos. Depending upon how many embryos are formed, whether they are day 3, day 5, we decide whether to go for a same cycle transfer or different cycle transfer. Like I said before, nowadays we do freeze all cycle. That means we have decided before the cycle that we would be freezing all the embryos, whatever we are getting, 1, 2, 4, 5, 10, 11, 12, whatever we are getting. We'll freeze all the embryos, let the period come, withdrawal bleeding come, and we will transfer in the next or maybe the next to next cycle. Why do we freeze this? The moment we are giving a gonadotropin injections for the formation of the follicles, for the recruitment and the formation maturation of follicles, it leads to a lot of estrogen production in the body. The moment the estrogen increases, this estrogen has got adverse effect on the endometrium of the uterus. This is the endometrium where we are going to transfer the embryo. And if the endometrium is not receptive because of the increase in estrogen, then the chances that the embryo transfer may fail become high, and that is why when we used to do a single cycle, the same cycle transfer, the success rate used to be somewhere between 30 to 35%. When we are doing a frozen embryo transfer cycle, in that cycle we do not give these gonadotropin injections for the formation of follicle. That is why the estrogen level is low, and that is why the chances of success are about 50 to 60%. So the next question comes, how do we do a frozen embryo transfer cycle? Now, I have told before also, IVF or test tube baby is like farming, where the uterus or the endometrium is a farm or agricultural land, and the embryo which we put is like a seed. It is the seed in the soil theory. Seed is ready, the embryos we have preserved, Day 5 embryos we have got and we have cryopreserved them. Now we have to prepare the farm, we have prepared the soil, that is the endometrium we need to prepare. There are two ways to go about it. Either it can be done in a natural cycle or it can be done in an HRT cycle or a hormone replacement therapy cycle. Previously we used to do in a natural cycle, but what we have found is in a natural cycle there is a premature progesterone rise and that leads to the failure in success rates. So what we have done is we start with a simple HRT cycle in every case. On day 1 or day 2 of the cycle we start with an estrogen. That estrogen is mostly estradiol valerate or estradiol hemihydrate. Most of them have got a same result. We start in the dose of 2 milligram 1 tablet twice daily or 1 tablet thrice daily from second day. The main purpose of starting estrogen from the first or the second day is to suppress the FSH. The moment the estrogen is started in 4 to 6 milligram dose, that FSH would be suppressed. The moment FSH is suppressed, the follicle would not start forming. And the moment the follicle would start not forming, because the estrogen level would not rise because of the follicle formation, there would be no rise in the LH and progesterone. There would be no premature rise in progesterone levels. So for first 3-4 days, we start with a 2 milligram tablet twice daily or thrice daily. And then after 4 or 5 days, we make it 2 milligram thrice daily or 2 milligram twice daily, and then we evaluate for an endometrium on 9th to 11th day. If the endometrium is reaches about 8 millimeter, which is our minimum criteria of 8 millimeter, then we again wait for 1 or 2 days, and then after 1 or 2 days continuing the same estrogen dose, we do a progesterone test. If that progesterone test is less than 1.2, then and only we start with a progesterone hormone in a form of a vaginal progesterone, in form of a dihydrogesterone, or in form of a injectable progesterone. That depends upon institute to institute, but basically we are starting the window of implantation from that point onwards. So the moment the progesterone level of a patient on the day of a good endometrium, which is more than 8 millimeter, is about less than 1.2, then we start progesterone. Most of the institutes start vaginal progesterone 400 milligram twice daily, and the time of that progesterone is very, very important. Mostly it is kept at 9 a.m. 9 p.m. for the convenience, and some people also add dihydrogesterone, which can be again at 9 a.m. 9 p.m. Some people also add progesterone injections, and if it is a day 5 transfer, that is we have got a blastocysts which are ready, then we transfer on day 6 after starting the progesterone. Suppose I am starting the progesterone vaginal capsule or dihydrogesterone on Monday, then Saturday at about 10 a.m. or 11 a.m. I would be transferring the embryos. So this is how a frozen embryo cycle transfer works. The advantage for frozen embryo cycle is we have got the embryos, we know how many days, whether it is a day 3 embryo or a day 5 embryo. Nowadays most of the people, they transfer day 5 embryo only, that is a blastocyst, because the chances of success with the blastocyst transfer increase. Now before transferring the embryo, because those have been cryopreserved, we do some procedure called as thawing of the embryos. That means because they have been preserved in a liquid nitrogen at minus 270 or whatever the temperature is, they need to be taken out there at 37-degree temperature. They need to be warmed, and then they need to be loaded in embryo transfer catheter, and then they will need to be transferred. So the success rate, as I have already mentioned, it is about 50 to 60%. That depends upon the various factors, whether the female has a fibroid, whether the female has a any kind of a uterine abnormality in form of a unicornuate uterus or a bicornuate uterus, or there is a adenomyosis which is affecting the endometrium, or the triple line endometrium is not there, or there is some kind of a polyp or some kind of a submucosal fibroid which is very, very small, or a intramural fibroid just abutting the cavity. These all factors, they may affect the success chances, and most importantly is the endometrium. So does this frozen embryo transfer have any risk? It is usually a painless procedure. The transfer process is almost like an embryo transfer. On the day of embryo transfer, the patient is told to come at the hospital. Then the patient is asked to not pass the urine, drink water, and after every 15 minutes, 20 minutes, the staff or the doctor checks with an ultrasound how much bladder is full. They want a minimal level of urine in the bladder, because the full bladder, what it does is it makes the uterus relatively straight and transfer becomes relatively easier. The moment the patient is in the position, everything is fine, lithotomy position is given, cusco speculum is inserted, and the plunger is inserted. Then once everything is ready, the embryologist is instructed to take the embryo, to load the catheter, look it under the microscope, and that loaded catheter with 1 or 2 embryos is passed on to the doctor who is transferring. It is done always under the ultrasound guidance. One staff is directly putting the ultrasound probe on the abdomen of the patient to guide. And the moment you pass the embryo transfer catheter just beyond the internal os, you go up to the fundus. You don't touch the fundus. Somewhere about 1.5 to 2 centimeter from the fundus, you stop, and then you slowly inject the embryos. Once you have injected the embryos, slowly you take out the catheter, and the embryo transfer catheter again is checked under the microscope to confirm whether the embryos have been injected inside the uterus or not. Once that is done, the plunger is taken out, the patient is asked to lie down for about 20, 30, 40 minutes, and then she can walk up and go and pass the urine. So this is how a frozen embryo transfer is done. Usually it is not done under anesthesia. We do not advise any kind of bed rest after frozen embryo transfer. First 2 to 3 days rest is required, but no bed rest. On the contrary, the studies have shown that if there is an excessive amount of bed rest after embryo transfer, the chances are relatively less. So first few days, 1 or 2 days, it is fine that you can rest. But what we generally advise is no lifting of heavy weights, no intercourse, no heavy activity. But the routine work can be done. You don't need, if you're working, you don't need to take leave from your office. You can go to office. The only thing is that you should not be lifting heavy weights, no mopping, no washing clothes, all those kind of things. So there are various questions about frozen embryo transfer. We will discuss what is the best time for a frozen embryo transfer. We have already told it, frozen embryo transfer is done somewhere about day 16, day 17 of the cycle. Because the chances, day 2 we start estrogen, day 10 we evaluate the endometrium. If the endometrium is fine, again we wait for a couple of days. Then on day 10 or day 11 we do a progesterone test. If it is normal, we start progesterone capsules, injections or tablets. And day 6, after the starting of the progesterone capsule, we do embryo transfer. So it is done somewhere between day 15 to day 17. So do's and don'ts after embryo transfer, like I said, the diet which we are following, we can do normal diet. It should be good antioxidant diet, avoid gluten, avoid refined carbohydrates. There should be good stress relaxation, the meditation, deep breathing, the manifestation, it works sometimes, the positive reinforcements, all those kind of things need to be done. What is the perfect lining for an embryo transfer? Somebody has asked. Minimum endo and lining for an endometrium transfer we want is triple line, which is a minimum 8 millimeter. Sometimes there is a persistently thin endometrium. In that, minimum should be about 7 millimeter, but ideally 8 millimeter, but definitely not more than 10, 11 millimeter, because if it is more than 10, 11 millimeter, that would signify there is some kind of a polyp or there is more estrogen in the body. Do we need to go for an estrogen and a progesterone test? Estrogen is not mandatory, but progesterone is definitely mandatory. Day 11, day 12, once the endometrial lining is normal. The estrogen can be done for trial, because if estrogen is more on the day of starting progesterone, that means this patient is more likely to require some kind of a low molecular weight heparin, because the chances of preeclampsia and all those kind of things would increase in this patient. And if it is more than 900 nanogram per ml, then the chances that it may fail. It has to be somewhere between 400 to 700. Only. Ideal should be about 300, 400. When is frozen embryo transfer done? After period, we start on first or second day of cycle. If it is a withdrawal cycle, progesterone withdrawal or OCPL withdrawal, we can even start day 2, day 3. But ideally, day 1, day 2 should be the time when should start it. Are there any foods to thicken the lining of uterus? Well, they say you can eat beetroot, which contains some kind of an L-arginine component, which helps in increasing the blood flow of endometrium. But technically speaking, there are no specific foods. You can eat whatever you want. Does walking thicken the endometrium lining? Walking is a good way of reducing the stress, improving the metabolism. It will improve the general health being. But there is no specific way by which walking would thicken the endometrial lining. What to drink after embryo transfer? Whatever you may feel like, you can drink after embryo transfer. Which fruit is best after embryo transfer? You can eat any fruit you like, but avoid fruit with high glycemic index. They say papaya contains some kind of a bromelain enzyme, especially the hardcore part. If you want, you can have those papaya. Which grade of embryo is best? Again, the embryologist would decide, especially blastocyst. Blastocyst of a good grade would be do. How to sit after embryo transfer? I mean, there is no specific position to sit or lie down. What we have to understand is that uterus is not like a cavity or a pipe. The moment you put the embryo would come up. Many people feel like if I may walk or I may run or I may sneeze, the embryo would come out. No, it doesn't happen like that. The endometrium is like a wall, and in those walls we keep the the embryo. So can I pee immediately after embryo transfer? After embryo transfer, we normally ask not to go to washroom for at least 2-3 hours. After that, you can go to use a washroom. Can I wash my hair after embryo transfer? Medically speaking, there is no logic of not washing the hair. I mean, depends. If you want to wash, you can definitely wash, but there is no such guidelines. How to increase the embryo transfer success? I've already mentioned the diet, the lifestyle, but those things have to be continued for at least couple of months before embryo transfer. Positive manifestations, reinforcements, deep breathing exercises, stress relaxation, meditation. Are there any symptoms of a successful embryo transfer? See, by the seventh day after embryo transfer, the embryo starts secreting. If it is implanted, start secreting HCG. We can earliest pregnancy we can know after seventh day of embryo transfer. But to be on the safe side, we do it on the 14th day. Is walking okay after embryo transfer? Yes, definitely walking is okay. How to sleep after embryo transfer? You can sleep in any position, whatever you like. Can I eat banana after frozen embryo transfer? Yes, you definitely can eat banana, a medium sized banana. Does sneeze will have any effect on an embryo transfer? I mean, like I said, ideally for first few days you should avoid any kind of things which would increase your intra-abdominal pressure. The logic would say so, but sneeze again, it would not throw the embryo out of the body. So, and anyway, it is an involuntary thing. You cannot control the sneeze. So, frozen embryos, how long they remain viable? Technically speaking, the frozen embryos can be preserved for as long as 8 to 10 years. There have been studies that even after 8 to 10 years, the frozen embryos have been used. How long does the embryo implantation take after the transfer? The window of implantation, like I said, is about 5 to 7 days, and if embryo has to stick, it will stick within 1 to 2 days. There are various methods of getting the embryo to stick. You can use an embryo glue. There are different methods. We will discuss those when we will discuss about the embryo endometrial receptivity array. Which is the best day to freeze embryos? Ideally nowadays, most of the people, they freeze embryos on day 5, sometimes day 6. Blastocyst is the best time to freeze the embryo. Is it better to transfer on day 3 or day 5? Nowadays, most of them, they do not do day 3 cleavage stage. They don't do, because out of day 3, 40 to 50% only would reach to day 5. So it is better we know how many embryos reach day 5. So this was about frozen embryo transfer. There are various things which can be added to a frozen embryo transfer. Some people add endometrial scratching, the cycle before. We would discuss in upcoming videos how to improve, do how and when to do endometrial scratching. Some people add a dash of lower molecular weight heparin to improve the chances of success. Again, they are most useful if there is a documented case of an APLA positive or multiple past IVF failures or multiple past miscarriages or history of ANA positive. Then we use, some people they routinely use steroids or Vizolone or prednisolone routinely. They can be used especially if the female has got some kind of antibodies, thyroid antibodies or ANA positive antibodies in her blood, then they can definitely be used. Some people also use IVIG or intralipid. Again, they are on a trial basis, not recommended routinely. Some people use intramuscular progesterone injections. They are very, very good, but they are very, very painful also. Some people use progesterone gels. I personally am not in favor of using progesterone gels because I think it becomes messy and it is not that effective. In my opinion, the vaginal pessaries, they work relatively well and they are less costly than the use of progesterone gels. If you have any questions, you can send us to the comment box. We will be happy to reply. Please like the video, subscribe to the channel and share the videos. Thank you. Bye-bye.